Imagine waking up at 3 a.m., heart-pounding chest, feeling like it's in a voice. Can't catch your breath. Scary, right? That's the reality of acute coronary syndrome, ACS, a heart emergency. We've got some new guidelines to help us. Big thanks to London Heartbeat's Aid Academy in the UK for their support over 150 cardiology courses. Check out their Facebook, Instagram, Spotify, and YouTube for free updates. We're diving into the 2025 ACA JEG guideline for the management of patients with acute coronary syndromes. I've got an expert here. Welcome to the show.
Thanks. Glad to be here.
You're a cardiology pro, and this guideline is massive. Where do we start?
The beginning. It lays the groundwork.
What's the big picture?
It focuses on acute management of ACS, unstable angina, and STEMI and STEMI.
Whoa. Break it down. What do those terms mean?
Basically, when blood flow to the heart muscle is compromised, usually a blockage in the coronary arteries.
Like a traffic jam in the heart.
Exactly. And depending on how bad and where it is, we call it unstable angina and STEMI or STEMI.
All serious, right?
Absolutely.
Right.
Need quick attention. The guideline focuses on type 1 MI triggered by a sudden event like a plaque rupture, not type 2, which is more supply and demand.
Like the classic heart attack in movies.
Exactly. The guideline emphasizes recognizing it fast and treating it fast time is of the essence.
Right. The longer the heart is without oxygen, the worse the damage.
Yeah.
Time is muscle.
Exactly. Now, this guideline is a team effort. American College of Cardiology, the American Heart Association, American College of Emergency Physicians, and a few others.
So not just cardiologists. They're bringing in emergency medicine, EMS, interventional cardiology.
Right. They know managing ACS takes a team from first responders to the specialists.
Okay, a multidisciplinary team goal is practical recommendations for managing ACS based on science. Important mission.
It is. They've looked at tons of research and made it into advice for doctors and nurses.
A cheat sheet for the best ACS care.
That's a good way to think of it. Now, the guideline starts by explaining what happens in the body during a heart attack.
Let's get into it. What's happening in the arteries?
Picture plaques, cholesterol, and other stuff building up in your coronary arteries. They can become unstable and rupture.
A time bomb in the arteries.
Precisely. And when a plaque ruptures, it causes a chain reaction. Blood clots block blood flow to the heart muscle.
A roadblock cutting off the heart supply line.
Exactly. And this lack of blood flow, called ischemia, can damage or kill heart muscle cells. That's a myocardial infarction heart attack.
Plaque rupture, blood clot, ischemia, heart attack. A chain reaction with bad consequence.
That's why catching it early and intervening is so important. The faster we restore blood flow, the better.
Right, because time is muscle. Now, the guideline stresses the importance of assessing and managing a patient quickly. I imagine that starts with recognizing the signs of ACS.
You got it. The guideline says any chest pain should be taken seriously, especially with shortness of breath, sweating, nausea, or pain in the arm or jaw.
So don't dismiss it as heartburn. We need to think about ACS.
Exactly. And the guideline tells us what to do when we think a patient has ACS.
Walk me through it. What's the first thing?
12-lead ECG within 10 minutes of seeing the patient. It's essential to identify STEMI quickly.
Hook them up to the ECG right away. Why so important?
The ECG shows us the heart's electrical activity stemma has very specific changes on the ECG that tells us a major coronary artery is completely blocked.
A roadmap showing the blockage location and how bad it is. What if the ECG isn't clear?
Do serial ECGs, meaning repeat the test, and also measure cardiac troponin CTN using a high-sensitivity assay?
Wait, what's cardiac troponin and why is it important?
It's a protein released when heart muscle is damaged. Elevated troponin means a heart attack happened.
So it's like a smoke detector.
Exactly. And the high-sensitivity assays can detect even tiny amounts of troponin.
So ECG and troponin, the cornerstones of the initial assessment.
Absolutely. Got to be done fast, minutes, not hours.
Right, time is muscle. What happens if it looks like STEMI based on the ECG and troponin?
Call the cardiac catheterization lab right away, even before the patient gets to the hospital.
They're prepping the cath lab before the ambulance gets there.
That's right. Got to be ready to do percutaneous coronary intervention, PCI, fast.
PCI, that's where they open the artery with a balloon and a stent.
Exactly. The goal is to get that artery open within 90 minutes of first contact.
Wow, 90 minutes. That's tight.
It is, but it makes a huge difference. The faster we open the artery, the less heart damage.
So every second counts in STEMI. What if they're not near a hospital that can do PCI?
Then we use fibrinolytic therapy, clot-busting meds through an IV. Not as good as PCI, but it can be life-saving.
So fibrinolytic therapy is our backup.
Yeah.
You mentioned that EMS is crucial in managing ACS early on. Can you explain more?
Sure. The guideline highlights the importance of EMS personnel who are trained to interpret ECGs.
So they're assessing the patient in the ambulance.
Exactly. They can see STEMI on the ECG and let the hospital know so they can activate the cath lab.
Incredible. They're like mobile cardiologists. Okay, so we've covered the initial assessment and how urgent treatment is in STEMI. What about unstable angina and NSTEMI? How are those handled?
The guideline has recommendations for those too, focusing on risk stratification and a personalized approach.
Risk stratification. What's that?
Figuring out the patient's risk of complications, like another heart attack, stroke, or even death, helps us decide on treatment and what level of care they need.
Like triage for heart patients.
Yeah. The guideline recommends using risk scores like the GRACE and TMI scores to help with this.
And these scores use things like the patient's age, medical history, and their test results.
Exactly. They give us a bigger picture of the patient's risk.
Okay, so risk stratification is key. You also mentioned a personalized approach. What does that mean?
It means creating a treatment plan specifically for that patient, considering their risk factors, what their symptoms are, and what they want.
So not one size fits all.
Definitely not. The guideline emphasizes that each patient is different and treatment should reflect that.
Makes sense. Before we finish this part of our deep dive, the guideline mentions something called urgent echocardiography. What?
Echocardiography, or echo, is an ultrasound of the heart. It lets us see the heart's structure and how well it's working. Really helpful for ACS patients.
Another tool in the toolbox.
Right. The guideline recommends an urgent echo for patients whose blood pressure and circulation aren't stable, and for those we think might have mechanical complications.
What does that mean, unstable blood pressure and circulation?
It means their blood pressure and circulation aren't stable. They might be in shock or at risk of their organs failing.
So it's serious.
Yeah.
What about mechanical complications?
Things like a rupture in the heart wall, a leaky heart valve, or a problem with the heart pumping.
Okay, so echocardiography can help find these complications and help guide treatment.
Exactly. It helps figure out how bad the situation is and what we need to do.
Really helpful. We've covered a lot, but it's clear that assessing and managing ACS is complex and things change quickly. Every decision matters and time is super important.
I agree. And we've only just started. There's a lot more to this guideline, from specific treatments to long-term management.
Looking forward to diving deeper into those in part 2.
So in the first part, we focused on that initial assessment, how crucial it is to act fast in ACS.
Yeah, it's incredible how much happens in those first few minutes and how important those early decisions are.
You got it. Every second counts.
Now that we've covered the basics, let's get into the specifics of treatment. What does the guideline say?
Okay, so the guideline breaks down treatment into a few key areas: standard medical therapies, then reperfusion strategies for STEMI, how to manage NSTE-ACS, and then specific situations like cardiogenic shock and mechanical complications.
Sounds like a good plan. Let's start with those standard medical therapies. What are the main medications for ACS?
The guideline recommends hitting it from all sides, addressing different aspects. It starts with oxygen therapy, but they've gotten more conservative about using oxygen now.
Oh, so not everyone with ACS gets oxygen automatically.
Right. They only recommend oxygen if the patient's oxygen saturation is below 90%.
Yeah.
We've learned that too much oxygen can actually be harmful.
Interesting. So it's finding that balance, enough oxygen, but not too much?
Exactly. Then we have pain management, which is super important for the patient's comfort. Morphine is still the preferred drug in most cases.
Morphine. That's a strong painkiller.
Yeah.
Why is it the go-to for ACS?
It's good at relieving that chest pain, and it also helps with anxiety, which is understandable during a heart attack.
Makes sense. It's not just physical pain, but the emotional part too. I noticed that the guideline says not to use NSAIDs except aspirin. I thought those are good for pain.
They are, but with ACS, they can actually increase the risk of problems. They can interfere with how platelets work and make things worse.
Got it. So aspirin is still a cornerstone of ACS treatment, but be careful with other NSAIDs. What about antiplatelet therapy? Those are important for preventing clots, right?
Absolutely. Antiplatelet therapy is essential in managing ACS. The guideline recommends using aspirin plus an oral P2Y12 inhibitor like clopidogrel, prasugrel, or ticagrelor.
Lots of choices there. How do they pick which one to use?
It depends on things like how likely the patient is to bleed, what type of ACS they have, and if they're going to have PCI.
Another example of personalized medicine, finding the right treatment for that specific person.
Exactly. And the guideline also talks about using intravenous glycoprotein IBA inhibitors like abciximab or tirofiban in certain situations, especially during PCI.
Those are the big guns of antiplatelet therapy.
Yeah, you could say that. They're very powerful, but there's a higher risk of bleeding.
So they're used when the benefits are worth the risks. Okay, what about anticoagulation? Those are the meds that stop clots from forming.
Right. The guideline says to use parenteral anticoagulation, meaning giving it by injection or IV for all ACS patients, no matter if they're having PCI or getting fibrinolytics.
So everyone gets anticoagulation even if they're not having a procedure.
Yep, it helps stop new clots from forming and lowers the risk of complications.
Okay, so we've got oxygen pain management, antiplatelet therapy, and anticoagulation. Anything else in that standard medical toolkit?
Can't forget about those lipids. Got to get that cholesterol under control. High-intensity statin therapy for all ACS patients. That's what the guideline says.
Makes sense. Got to tackle that cholesterol. What if statins aren't enough on their own?
Then the guideline suggests adding a non-statin lipid-lowering agent like ezetimibe or a PCSK9 inhibitor for those whose LDL cholesterol is still too high, even with the maximum statin dose.
So they're really aggressive with the lipid management. What about beta blockers? I know those are used a lot for heart problems.
They are, but the guideline is more careful about using them now. They're definitely good for some patients, especially those with ongoing ischemia or high-risk features, but not for everyone with ACS.
So it's being strategic about when to use them.
Exactly. The same goes for RAAS inhibitors. Those can help protect the heart, but it's about finding the right patients who will benefit.
Personalized medicine, again, weighing the risks and benefits for each person.
That's it. Now, we've talked about those general medical therapies, but let's talk about reperfusion strategies, specifically for STEMI.
Ah, yes. Those dramatic rushing to the cath lab scenes we see in the movies. It sounds like getting things moving quickly is key in STEMI.
Absolutely. They call it regional systems of STEMI care, which basically means hospitals and EMS have to work together really well to make sure patients are getting the fastest, most effective treatment possible.
So it's like a well-coordinated machine, everyone knows their role, and they're all working together.
Exactly. And at hospitals that can do PCI, primary percutaneous coronary intervention is the best option. Remember, the goal is to open that artery within 90 minutes of first contact.
Right. Time is muscle. But what happens if the nearest hospital can't do PCI?
Then fibrinolytic therapy is the way to go.
Yeah.
The guideline has details about the different types of fibrinolytics and when to use them. It's about having a system where we can restore blood flow quickly no matter where the patient is.
So it's having that backup plan, knowing that not all hospitals have the same resources.
Precisely. Now let's switch gears and talk about NSTE-ACS, or non-ST elevation acute coronary syndrome. This type of ACS is a little different.
Yeah, from what I understand, NSTE-ACS can be trickier than STEMI. The blockage might not be as bad, and the symptoms can be harder to spot.
Right. It can be more difficult to diagnose and manage. The guideline talks about two different strategies: routine invasive and selective invasive, depending on the patient's risk.
Can you explain those? What determines which strategy they go with?
So a routine invasive strategy means doing coronary angiography pretty quickly. Angiography is basically a detailed X-ray of the coronary arteries.
Okay, so it shows them the blockage.
Exactly. And this approach is usually used for patients who are more likely to have complications. Things like angina that keeps coming back, hemodynamic instability, meaning their blood pressure and circulation aren't stable, or high-risk scores, would all point towards this strategy.
So if they're high risk, they go straight to angiography. What about the selective invasive approach?
That one involves waiting a bit and watching closely, but they're monitored carefully. If the patient stays stable and the risk seems low, they might do non-invasive testing first, like a stress test or a cardiac CT angiogram.
Those are less invasive ways to see how the heart is working and check for blockages.
Exactly. Angiography would then be done if those tests show a significant blockage or if there are ongoing problems.
A more conservative approach for those who don't seem as high risk.
That's it. And the guideline says it's important to talk to the patient and make the decision together, considering the risks and benefits of each approach.
I'm noticing a pattern here of personalized medicine. It's not one size fits all.
You got it. This guideline is all about tailoring treatment to the individual patient, considering their specific situation and risk factors.
Makes sense. Let's talk more about coronary angiography. It sounds like a really important tool.
It is. It gives us a clear picture of the coronary arteries, helps us find blockages and decide what to do next.
And you mentioned that sometimes they use other imaging techniques during angiography, like IVUS and OCT.
Right. IVUS is intravascular ultrasound, and OCT is optical coherence tomography. These give us really detailed images from inside the arteries, much clearer than regular angiography.
Wow, so it's like a tiny camera traveling through the arteries, showing them the blockages up close.
Exactly. And these techniques are helping us place stents more accurately and improve outcomes.
That's incredible. So we've talked about managing single vessel disease, but what about multi-vessel coronary artery disease when there are blockages in multiple arteries? That sounds even more complex.
It is, and the guideline covers that too. It talks about how managing multivessel disease is different in STEMI and NSTE-ACS.
What are the main differences there?
In STEMI, the focus is on the culprit lesion, the blockage that's causing the heart attack at that moment. They usually fix that first and then might check other blockages later.
So they prioritize the most urgent blockage in STEMI. What about NSTE-ACS?
For NSTE-ACS, the guideline suggests taking a more comprehensive approach, usually evaluating all the significant blockages. They recommend using physiological assessments like fractional flow reserve or FFR to help decide about revascularization.
FFR, what's that? It sounds pretty high-tech.
It is. It measures blood flow through a narrowed artery. It helps us figure out if a blockage is really restricting blood flow and needs a stent.
So it's not just about how narrow the artery looks, but how much it's actually affecting blood flow.
Exactly. FFR helps us avoid putting in stents unnecessarily and make sure we're focusing on the blockages that matter most.
That's a smart approach. So FFR helps decide about revascularization in NSTE-ACS. Are there any times when they recommend not doing PCI and multivessel disease?
Yes, actually. The guideline says to avoid PCI in one specific case, NSTE-ACS, complicated by cardiogenic shock.
Oh, wow. That sounds serious. Why would they not do PCI in that situation?
Because the evidence suggests that stenting a non-culprit artery in this case could actually make things worse. The risks are greater than the potential benefits. The focus is on stabilizing the patient first.
That makes sense. Speaking of cardiogenic shock, let's talk about that. What does the guideline say about managing ACS with that complication?
Okay, so cardiogenic shock is a life-threatening condition where the heart isn't pumping enough blood to meet the body's needs.
So it's like the heart is failing?
Exactly. It's a serious complication, and the guideline stresses how important it is to recognize it early and treat it aggressively.
What kind of treatment are we talking about?
The first thing is to find and fix the underlying cause, which is often a major blockage in a coronary artery. So early revascularization, ideally within 90 minutes, is crucial.
So PPCI is still the go-to strategy.
Yes, but often it's not enough on its own. The guideline also talks about using mechanical circulatory support, or MCS, devices.
What are those? I've heard of things like balloon pumps. Are those considered MCS?
Yep. An intra-aortic balloon pump, or IABP, is one type of MCS. It helps the heart pump better by making it work less. The guideline also mentions newer devices like microaxial flow pumps.
How are those different from the balloon pump?
Microaxial flow pumps are more advanced. They actually pull blood from the left ventricle and pump it into the aorta, basically taking over some of the heart's job. The guideline mentions a recent trial, the Danger SSOC trial, that showed promising results with these pumps in certain patients.
Wow, that's some really advanced technology.
Yeah.
So these MCS devices are like a lifeline for patients with cardiogenic shock, giving their heart a chance to rest and recover.
You could say that they give the heart time to heal while the reperfusion therapy is working.
This is all so important. But sometimes, even with the best treatment, complications happen. What does the guideline say about managing those mechanical complications after ACS?
You're talking about things like a ventricular septal rupture, mitral valve insufficiency, or even a rupture in the heart wall. Thankfully, these are less common now that we're better at restoring blood flow quickly, but they still happen.
And when they do, what's the plan?
The guideline is clear. Those patients need to be at a hospital that can do heart surgery. They might need an operation to fix the damage.
It's an emergency.
Often, yes.
Yeah.
And the guideline talks about using short-term MCS devices to stabilize the patient until they can have surgery.
Okay, so we've talked about mechanical complications.
Yep.
What about arrhythmias? Those can be pretty scary after a heart attack.
For sure. The guideline goes into managing both ventricular and bradyarrhythmias, which are slow heart rhythms. For ventricular arrhythmias, they talk about implantable cardioverter defibrillators, or ICDs.
Those are the devices that shock the heart back into rhythm, right?
That's right. They can be life-saving for patients at risk of sudden cardiac death. The guideline explains who should get an ICD, considering things like their left ventricular ejection fraction, or LVEF, which measures how well the heart is pumping.
So not everyone who has a heart attack needs an ICD.
Right.
It's for those who are at higher risk.
Right. And for patients who don't need a permanent ICD but are still high risk, they might use a temporary wearable cardioverter defibrillator until a decision is made.
Interesting. So there are options for both short-term and long-term arrhythmia management. What about bradyarrhythmias?
For those, a permanent pacemaker is often the answer, especially in cases of persistent heart block.
So a pacemaker helps keep the heart beating regularly.
Exactly. It steps in when the heart's natural pacemaker isn't working right.
Got it. So managing arrhythmias is a key part of ACS care. We've covered a lot. Are there any other things to consider while the patient is still in the hospital?
A few more. The guideline talks about when to admit patients to the cardiac intensive care unit, or CICU, which is for those who need closer monitoring and more specialized care.
What determines if someone needs the CICU?
Things like angina that doesn't go away, hemodynamic instability, uncontrolled arrhythmias, or if the reperfusion wasn't successful.
So it's for the higher risk patients. Anything else?
The guideline also talks about managing anemia, which is surprisingly common in ACS patients and can lead to worse outcomes.
Anemia. Isn't that just low iron?
Sometimes, but it can also be caused by bleeding, especially because of the antiplatelet and anticoagulant medications.
Right. With all those medications, it makes sense.
Exactly. The guideline talks about the risks and benefits of blood transfusions and says that in some cases, being more liberal with transfusions might be a good idea.
So it's not a simple yes or no on blood transfusions. It depends on the individual situation.
Exactly. They also discuss telemetry monitoring and how long patients stay in the hospital after ACS.
Telemetry is basically continuous heart rhythm monitoring, right? How long do they usually keep patients on telemetry?
It depends on their risk and how stable they are. But the trend is towards shorter hospital stays thanks to faster reperfusion and better medical management. They even mention a tool called the ZWOL score, which helps figure out who might be able to go home earlier.
So it's not just about the procedure itself, but making sure they're stable enough to go home and recover safely.
Right. Speaking of going home, discharge planning is a big part of the guideline.
Of course, because it's not just about getting them stable in the hospital. It's about making sure they do well once they go home. What does the guideline recommend for discharge planning?
One of the most important things is patient education.
What does that involve? Is it just giving them some pamphlets on their way out?
Definitely not. It's about giving patients the power to take control of their health. The guideline highlights the importance of structured education programs that cover everything from understanding their diagnosis and treatment plan to making lifestyle changes, managing medications, and recognizing warning signs.
So it's about giving them the knowledge and skills to manage their condition and prevent future problems.
Exactly. And they also need to understand why it's so important to take their medications correctly, knowing how and when to take them.
Right, because even the best medications won't work if they're not taken the right way. What about cardiac rehabilitation? I know that's often recommended after a heart attack.
The guideline strongly recommends cardiac rehabilitation, or CR. They say there's evidence that it reduces death, heart attacks, and having to go back to the hospital. Plus, it helps people function better and improves their quality of life.
That's pretty convincing. Why wouldn't someone do CR? What does a typical CR program look like?
It's a team approach that includes supervised exercise training, nutrition counseling, managing risk factors, and psychological support.
So it's a whole person approach, not just about exercise.
Exactly. And the guideline mentions that there are different types of CR programs, including ones at a center and ones that can be done at home so more people can participate.
That's great, so they can choose what works best for them.
Right. Now, before we talk about long-term management, I want to mention one more part of discharge planning: medication reconciliation.
That's making sure the patient's medication list is correct and up to date, right? Why is that so important when they're going home?
Because it helps prevent mistakes with medications and ensures a smooth transition. The guideline says it's crucial to look at all the medications a patient is taking, including any new ones they're going home with, and make sure there are no duplicates, no interactions, and no unnecessary prescriptions. They also need to make sure the patient understands how and when to take their medications and how to get refills.
So it's a final check to make sure they're leaving with the right medications and the right instructions.
Exactly. A key step in preventing readmissions and complications.
Okay, so we've covered managing ACS in the hospital and the key elements of discharge planning. Now let's talk about long-term management. What are some important things to remember from the guideline?
The guideline gives detailed recommendations on different aspects of long-term management, like diabetes strategies, managing patients who need anticoagulation, lipid-lowering therapy, and even the role of newer diabetes medications.
Okay, lots to cover there. Let's start with DAPT, or dual antiplatelet therapy. We talked about how important DAPT is in the acute phase of ACS, but what about long-term? How long do patients usually stay on DAPT?
The guideline recommends at least 1 year of DAPT with aspirin and an oral P2Y12 inhibitor for patients who aren't at high risk of bleeding. This is for both STEMI and NSTE-ACS patients who had PCI.
So 1 year of DAPT is standard unless there are bleeding concerns.
Right, and even then they're trying to minimize bleeding risk without increasing the risk of ischemia. One strategy they mention is switching to ticagrelor monotherapy after at least 1 month post-PCI in appropriate patients.
Hold on, monotherapy. That means stopping the aspirin and just taking ticagrelor.
Exactly. There's more and more evidence suggesting that this approach can reduce bleeding without increasing the risk of heart attacks or other ischemic events.
Wow, that's interesting. So they're basically fine-tuning the antiplatelet regimen to lower the risks.
That's a good way to put it. It's about personalized medicine, again, finding the right balance for each person.
Okay, so they recommend at least a year of DAPT with the possibility of switching to ticagrelor alone. But what about patients who need anticoagulation too? That sounds complicated.
It is, and the guideline acknowledges the challenges of managing patients who need triple therapy, aspirin, a P2Y12 inhibitor, and an anticoagulant. Bleeding risk is a big concern in those cases.
So how do they handle that?
They recommend carefully weighing the benefits of each therapy against the bleeding risk. They suggest thinking about stopping aspirin 1 to 4 weeks after ACS or PCI in patients who need anticoagulation long term.
So they're basically prioritizing the anticoagulation over the aspirin in those cases.
Yes, often. The guideline also mentions that DOACs, or direct oral anticoagulants, are generally preferred over warfarin in this situation. They're safer.
Okay, so DOACs plus a P2Y12 inhibitor, usually clopidogrel would be the usual regimen for those needing triple therapy.
Exactly. And the decision of whether to continue anticoagulation with or without antiplatelet therapy beyond 12 months is best guided by the 2023 AACC guideline for managing chronic coronary disease.
Right, because at that point they're moving from acute to chronic management.
Precisely. Now, while we're on medications, the guideline also emphasizes the importance of lipid-lowering therapy after ACS.
We talked about high-intensity statins being the standard during the acute phase, but what about long-term?
Same idea. The guideline says high-intensity statins should be continued long-term, and additional lipid-lowering agents might be needed to get those LDL cholesterol levels down.
So it's not just about getting them stable in the hospital, it's about managing cholesterol for the long haul.
Absolutely. It's a lifelong commitment.
Speaking of long-term management, the guideline briefly mentions two types of diabetes medications, SGLT2 inhibitors and GLP-1 receptor agonists.
You're right. Those medications have been getting a lot of attention in the diabetes world because they've been shown to have cardiovascular benefits. The guideline acknowledges that they might have a role in ACS management, but says we need more research to figure out the best way to use them.
So they're promising, but we need more data.
Exactly. The guideline also highlights other important preventive measures like getting the flu shot every year.
The flu shot. Why is that so important for ACS patients?
Because getting the flu can actually trigger heart attacks and other cardiovascular problems. So getting the flu vaccine every year can really lower this risk in ACS patients.
Wow, I didn't realize that. So it's not just about preventing the flu, it's about protecting the heart.
Exactly. A simple but effective way to reduce cardiovascular risk. They also mention the potential benefits of low-dose colchicine for reducing the risk of recurrent events after ACS.
Colchicine, isn't that for gout?
It is, but it also has anti-inflammatory effects. Several studies have shown that it might help reduce the risk of heart attacks, strokes, and other cardiovascular events in patients who have had ACS.
So it's being used for a new purpose. What's the consensus on colchicine for ACS?
The guideline says it might be helpful, but we need more research to be sure about its long-term effectiveness and to figure out the best dose and how long to use it.
Okay, so it's on their radar, but we need more data before making any strong recommendations.
Right. And lastly, they talk about the need for more research in ACS management. There are still a lot of unanswered questions and areas where we need more information to guide our decisions.
So it's not just about following these guidelines, it's about continuing to learn and explore.
Exactly. The guideline specifically mentions several areas for future research, like how long to use DAPT, the role of new diabetes medications in ACS, the long-term benefits of doing cardiac rehab at home, and using colchicine to prevent recurrent events.
So even with all the advances we've talked about, the quest for knowledge goes on.
It does. And I think this desire to learn and work together is what will ultimately lead to better outcomes for patients.
Absolutely. We've covered a lot of ground today. It's amazing how much goes into managing ACS, both in the hospital and long-term.
It is. It's a complex condition, but we're making progress all the time.
Well, this has been incredibly helpful. I feel like we've really gotten a good grasp of the 2025 ACCH guideline for the management of patients with acute coronary syndromes.
I agree. It's a great resource for healthcare providers and for patients, too.
Absolutely. And I think the key takeaway is that personalized medicine is the future of ACS care. It's not about one size fits all anymore. It's about finding the right treatment for each individual patient.
Couldn't have said it better myself.
Well, listeners, we hope you found this deep dive into the 2025 ACCA guideline for the management of patients with acute coronary syndromes informative and empowering. Remember, knowledge is power, And staying informed is the best way to protect your health and the health of those you love. Until next time, stay curious, keep learning, and take care. We've covered a lot in this deep dive into the 2025 ACAJ guideline for the management of patients with acute coronary syndromes, from the first moments of a heart attack to the long road to recovery.
Yeah, it's been a pretty thorough look at what's new.
As we wrap up, I'd love to get your expert take on the big picture. What are the main takeaways for our listeners?
I think this guideline really shows us that how we manage ACS is always changing. New research, new technologies, new treatments are always coming out, and it's so important for us healthcare providers to stay up to date.
It's like a constant learning process.
Exactly. This guideline gives us a strong base, but there's always more to learn. We have to be lifelong learners and always look for ways to improve how we care for patients.
That's a good reminder for all of us in healthcare. I'm also curious about what these guidelines mean for the bigger picture. How do you think they'll affect healthcare systems, patient care, and even society as a whole?
That's a good question. I think one of the biggest things is the focus on a truly integrated and multidisciplinary approach to ACS care. The guideline talks about how important it is for everyone to work together seamlessly. EMS, emergency departments, cardiologists, nurses, pharmacists, rehab specialists, everyone involved in the patient's journey.
So it's not just specialists working on their own, it's about breaking down those walls and working as a team.
Exactly. And the shift towards team-based care can not only improve patient outcomes, but also make things more efficient and improve communication in healthcare systems.
That's a win-win. You mentioned earlier that personalized medicine is emphasized in the guideline. Can you talk more about what that means in ACS care and how these guidelines are shaping that approach?
Sure. Personalized medicine means making treatment decisions based on the individual patient, considering their specific risk factors, how they present, what they prefer, and even their lifestyle and social situation.
So it's moving away from a one-size-fits-all approach and recognizing that different things work for different people.
Exactly. And these guidelines are full of examples of this, from risk stratification tools to the specific recommendations for antiplatelet therapy and anticoagulation.
It's about giving patients the power to be involved in their own healthcare decisions.
Absolutely. Shared decision-making is a key part of personalized medicine. We need to have open and honest conversations with our patients, explaining the risks and benefits of different options and helping them make choices that align with their values and goals.
That makes so much sense. It's about trust and a true partnership between patients and their healthcare team. Speaking of patients, I'm curious about your thoughts on the role of patient education in managing ACS. How does the guideline address this, and what are your thoughts on its importance?
Patient education is so important. It's not just about giving them information, it's about giving them the power to take care of their own health. The guideline stresses the importance of structured education programs that cover everything from understanding their diagnosis and treatment plan to making lifestyle changes, managing medications, recognizing warning signs, and even navigating the healthcare system.
So it's about equipping them with the knowledge and tools they need to be active in their recovery and long-term health.
Exactly. And it's not just during their hospital stay. Cardiac rehabilitation, which the guideline strongly recommends, is a crucial part of this ongoing education and support.
Right. ACS management doesn't end when they leave the hospital. They need ongoing support to navigate their journey.
Couldn't agree more. Now, to wrap up our discussion, I want to touch on one more thing highlighted in the guideline, the need for more research. Even with all the progress we've made, there's still a lot we don't know, and areas where we need more data to make the best decisions.
So it's not just about using these guidelines, it's about always asking questions, exploring, and pushing the limits of our knowledge.
Exactly. The guideline specifically mentions areas for future research like the best duration of DAPT, the role of newer diabetes meds in ACS, the long-term benefits of home-based cardiac rehab, and the use of colchicine to prevent things from happening again.
So there's always more to learn, even with all the advances we've talked about.
Definitely. And this constant pursuit of knowledge and collaboration is what will lead to even better results for our patients.
Well said. This has been a great discussion, and I feel like we've just scratched the surface. But I'm really optimistic about the future of ACS care.
Me too. With these evidence-based guidelines and a dedication to research and innovation, we're in a good place to make a real difference for our patients.
Listeners, we hope you found this deep dive into the 2025 ACCHA guideline for the management of patients with acute coronary syndromes informative and helpful. Remember, knowledge is power, and staying informed is the first step towards better health for ourselves and our loved ones. Until next time, keep learning and take care.